Okay,
Okay.
we're ready.
All right. Well, good morning. We might as well get started. We will probably have a few more people joining on this, and of course, this is being recorded so that for posterity and for those who haven't been on it right now. This is the EMS protocol revisions for the half-year protocol revisions for July 2021. Changes that are going to be, we're going to talk about, we have removed a couple medications, and we'll talk about why. Nitrospray, Geodon, added a couple of medications, Peridol and olanzapine, and then some other medication changes, increasing the dosage of our calcium gluconate to about double what it was before, using ketamine, again, for post-intubation sedation, Peridol to replace Zofran for pain management facilitation, and some changes, some refinements of our cardiac arrest and ACS protocols, specifically amiodarone to be a priority in Vfib, pulseless VTAC, epinephrine to be a priority in asystole PEA, reiterating that medical control is to be contacted for transport determination in Vfib and pulses of VTAC for if they're persisting. Just a simplification for your cardioversion joules, and then brief discussion of county operating procedures, the divert policy, ambulance transport to the sobering unit, medical examiner consult reference material, and then a few miscellaneous things, such as the map of 65 blood pressure 110 for target blood pressure, and the use of the term agitated versus combative when we're talking about behavioral health patients. All right, so the initial thing, we'll talk first about cardiac arrest. And I'm going to be going through just reiterating existing cardiac arrest procedures, established unresponsiveness, pulse and absence of pulse and respiration, continuous CPR for 2 minutes if the downtime is estimated to be greater than 5 minutes, if less than 5 minutes, or if bystander CPR, do CPR until the AED and monitor is applied, and then analyze. Apply EKG leads, defib pads, analyze and follow AED or paramedic instruction, continuous CPR for 2 minutes. Goal is then to get epinephrine in quickly in asystole and PEA. Goal in a shockable rhythm, i.e. Vfib or pulses VTAC, is epinephrine after the third shock and after the first dose of amiodarone. I'll go into that a little bit more in detail soon. Supraglottic airway, 100%, capnography throughout, IV TKO balanced salt solution, above the diaphragm is preferred. Now, preferred would be arm vein antecubital. Next preferred is humeral IO, but not in the pediatric case. IO tibial or femoral pediatric is the likely places. We can't place the tibia, well, we don't place the tibial or femoral in the adult, but you should have no problem getting the humeral IO in if there's no arm vein. And although it's not written down, the same rule is if you can't find an antecubital vein, if you can't find adequate supra above the diaphragm venous access, then go directly to the humeral IO, and I would say within 1 or 2 minutes of attempting to find the IO. You can or IV. You can always go back and add another IV if you get ROSC or you get obvious venous access. Use a weight-based system for treatment of pediatric cardiac arrest, and that's our Broslow type tapes or the hand-heavy guidelines. If the patient's not responding to treatments, then consider death in the field, and we won't go into that one today. Now, for Vfib pulsus VTAC, your sequence is determined by the paramedic or the machine says shock advised, then defibrillate, then immediately begin CPR for 2 minutes, assess the heart rhythm. If they're still in Vfib or pulsus VTAC, defibrillate, continue CPR for 2 minutes. And during that sequence, I would like to see amiodarone, 300 milligrams. Now, I don't like amiodarone in torsades, but I may be changing my mind by the next time we talk about that. It doesn't make any science sense to me to use it in torsades. The first thing I would use in the torsades would be use magnesium. So during this sequence, if they're in Vfib or pulsus VTAC, not torsades, I would give 300 milligrams of amiodarone. So this is after the second shock. Now, if you have difficulty getting your IV in, I would give it after the third shock, etc. Now, if amiodarone is contraindicated for some reason, then I would use lidocaine. Now, but in torsades, as I said, we use magnesium 2 grams bolus. Then we assess the heart rhythm. If they're still in Vfib, defibrillate. Continue CPR for 2 minutes. At that point now, I would give epinephrine. So this is epinephrine after the third shock. Assess heart rate, defibrillate if pulsus VTAC. If you continue CPR, then do your second dose of amiodarone, 150. Lidocaine, if amiodarone was for some reason contraindicated, continue epinephrine every 3 to 5 minutes. And then it says transport if not already initiated. Well, we're going to ask you to contact medical control to discuss this. There may be some other ideas that the medical control may want to suggest. Continue until ROSC or DIF criteria apply. If ROSC, we're going to target our O2 sats at 94, 96 and then follow the ROSC protocol, including adjusting for blood pressure, fluids, and or epi-drip or norepinephrine drip as needed. Going to take your 5 to 10 minute timeout while you're getting ready to transport, but you're preparing the patient for the transport and trying to address all the issues that may be occurring as the patient comes back to an ROSC rhythm. Airway should be addressed with minimal interruption to CPR. If the patient remains in persistent Vfib, VTAC, with more than 4 shocks, reposition the defibrillation pads. Now, this is assuming that I would prefer, if possible, that you initially start out with an anterior-posterior placement, and that works out really well if you have a Lucas device that you're going to be applying, because at that point you roll the patient to get them on the Lucas device, and you can also slap on your posterior pads. But if they start out in the anterior-posterior position and we end up with more than 4 shocks, persisting Vfib or pulsus VTAC, then we need to try to change the vector of shock, which would be simply going to the standard chest placements, or vice versa. Sodium bicarb is not recommended routinely, but in cardiac arrest with a known cyclic antidepressant, or patients with hyperkalemia, or patients who have had prolonged downtime, and so you know that they're acidotic, administer 1 milliequivalent per kilo, maybe repeated at half milliequivalent per kilo every 10 minutes if it's a prolonged code. Now, if there is a delay in getting your IV-IO access, epinephrine could be given in the same sequence, the same CPR sequence as the amiodarone. There's no reason that we just give one of the two are totally different drugs. So there's no reason that you couldn't give them during that same sequence. If persistent Vfib, VTAC after the 5th shock, contact medical control, if possible. And the note down here is amiodarone is a priority for Vfib, contact medical control if refractory to determine transport determination. Now let me talk to this a little bit more depth so you understand we're not just pulling this out of the air. This is a study that Josh Lupton from Oregon Health Sciences University did on the impact of time from arrival to amiodarone, lidocaine, or placebo in out-of-hospital cardiac arrest outcomes. Sounds pretty exciting, you know. We know we get a lot of out-of-hospital cardiac arrests, 375,000 people per year in the United States, 80,000 of which roughly have an initial shockable rhythm. They're pulses VTAC or Vfib. Upwards of 50% of out-of-hospital cardiac arrests with initial shockable rhythms developed a shock refractory arrest. It's sometimes referred to as a ventricular storm. Let's see if we can move this along here. There we go. So the objective of this study was to evaluate the impact of amiodarone or lidocaine compared to placebo when given early. And this study was done using ALPS data, basically. So, you know, we were part of that process, and we have a lot of data, and now they're going back and reanalyzing certain aspects of the ROC data. And we're going to make this a simpler. We have tons of different things, but this is basically the results. The amiodarone is the gray, lidocaine is orange, and the placebo is the blue. So early administration was defined so a priori. They just said, we're going to look at less than 8 minutes from arrival to give the drug. Now, that's to arrival on the patient side. So as you can see, ROSC on arrival, there's significant difference between placebo and amiodarone. The lidocaine arm looks a little bit more like the amiodarone, but it's significantly less. Now, survival to admission to the hospital is significantly different. Survival to discharge is significantly different. This is roughly almost 15% difference. And then functional outcome is also, which means neurologically intact, is also significantly different. And then in late admission of, which is more than 8 minutes after arrival at patient side, this is, there's not much difference between the arms. And of course, the functional outcome is absolutely the same, and literally there's no difference to discharge. Now, when this is all adjusted, and there's a lot more slides available that we didn't want to bore you with today, when you this. I'm having trouble moving around with my slides here. Okay. When you adjust for all the other things, the basic outcome came out that amiodarone and amiodarone alone, when given within 8 minutes of ALS arrival, is associated with significantly greater ROSC, survival to hospital discharge, and survival with a favorable neurologic outcome compared to placebo, as well as compared to lidocaine. Now, why could that be? Well, I mentioned earlier that that persisting VTAC is thought to be due to what is called a ventricular storm, which is thought to be due partly to both endogenous and exogenous, i.e. we supplied it, epinephrine. We all know that we love to give epinephrine in cardiac arrest. We've been taught that for a long time, and the reason we give it is primarily for the alpha effect, to raise the blood pressure, particularly in the aortic root, so we can try to drive blood to the coronaries. The downside of epinephrine, of course, it works well. It's been, we use it for all sorts of stuff, but it's got tremendous beta effect, which can cause too much irritability of the heart and actually can lead to persisting ventricular dysrhythms. And it's tremendously, it has tremendous effect on the oxygen requirement of the cardiac cell as well. So turns out that amiodarone is a pretty good beta blocker, and so it is thought that at least it would help to counter the effect of some of the exogenous epinephrine that we may be giving. And also, if you give it initially to a person who's in a ventricular dysrhythm, it may affect the endogenous epinephrine as well. So that's why we'd like to see that the amiodarone be given at least in the same sequence as the epinephrine for shockable rhythms, and also given as a as the first drug if possible. I'm going to give you, we've been talking about this for a little while now, and here's a interesting case that came in last, I guess it's a week and a half ago now. 50-year-old male collapsed in front of his wife after saying, "I think I'm having a heart attack." Well, he was. Wife called 911, began CPR, had no history of heart issues, etc. PCEP call went down at 7:14. It took 3 minutes to discharge it. CCASO and District 3 were dispatched along with AMR and Vancouver Fire. Vancouver Fire is at patient side at 1726. So there's our countdown because it was a BLS. No one who initially arrived could do any amiodarone treatment, etc. And iGel was placed 2 minutes. Waveform was good. Defibrillated roughly 2 minutes after getting there. Defibrillated again, another 2 minutes. IV was established, so 5 minutes to get the IV in, antecubital left. Defibrillated again, another 2 minutes. You notice these are nicely 2-minute things. And amiodarone was given. So we have defibrillation 1, defibrillation 2, and defibrillation 3. Took a while to get all this stuff, but amiodarone goes in first, and then epinephrine a minute later. So in the same sequence. Defibrillated again. Another IV was attempted, but was unsuccessful. Amiodarone 150 given. Defibrillated again. That antecubital now is there. Epinephrine's given again. Defibrillated again. Magnesium was given because somebody, one of the interpretations. This was marvelously documented too. There's probably 20 different rhythm strips and 12 leads in this, and at least one 12 lead in this documentation as well. The magnesium was given because they thought there were perhaps torsades. So magnesium, defibrillated again, epinephrine again, defibrillated again, defibrillated again. The pads are changed at 1743, so that's after about the 7th or 8th shock. And they were changed. They started out as an AP, and then they went to the anterior, the standard anterior placements. Video laryngoscopy was done. It placed a 7.5 tube. Vancouver Fire with one for one pass. Defibrillated again. Epinephrine given again. See a process here. Now, at about that time, they're on the phone talking to medical control about what else they can do and whether they're going to end up calling this or not. And then they get ROSC. Because the patient has been intubated, he now gets some fentanyl and then gets some midazolam. About 7 or 8 minutes later, they get a bradyrhythm, blood pressure's falling. They begin to try pacing. I think I would have preferred just to see an epi drip going on the patient rather than pacing. But, and actually they had never fallen that I could read below 60, so I wouldn't be too excited about that. He needed some fluids and that. And then got some more fentanyl and some more midazolam because he may have been bucking the tube a little bit. Altogether, we've got 11 defibrillations. When they got to the ER, they removed the pacer pads. Guess what happened? Pulses are lost again. CPR has begun again. Well, in the hospital, he arrested twice in the ED, got ROSC both times. 12 leads showed a STEMI. Went urgently to the cath lab. He arrested again on arrival at cath lab, was defib, got ROSC. Cath lab showed 99% LAD occlusion. They placed a drug-eluting stent with good flow, went to the ICU, improving LV function. His LV function to start with was in the 10% range, and by the time he got to the ICU after the cath lab, he was in about 40%, and he kept improving from that point on. They did controlled temperature management. because he had questionable neural findings in the ED. Now, he had a fair amount of, kept arresting, plus he had some fentanyl and some midazolam on board. They thought he was doing some purposeful, they didn't know if he was doing purposeful movement. He was moving all four, but they didn't know. So they kept him cold for about 24 hours. Then they warmed him. He was extubated perfectly well. The day after extubation, he was neurologically normal, complained of sternal discomfort from the CPR, more than likely, and he was sent home on day 4. Now, he actually could have gone home the day before, but they had to get him fitted for a life vest, one of the wearable defibrillators, because under the rules of engagement, he didn't qualify yet for an ICD, which is really what he needs. He has to be, because this arrest happened during a apparent STEMI event. He has to be at least 3 months out from the STEMI in order to get an ICD. So he's going to be wearing the portable one. But this was quite a remarkably good case and amazing outcome. And actually, everything in this is exactly what we would be looking for now. Early amiodarone, changing the pads, contacting medical control if you have a persisting Vfib. Okay, any questions on that before? Actually, you can save questions to the end if you want, or ask them now. Our cardioversion procedures for synchronized cardioversion, it's been too complicated. We just want to start simple doses for synchronized cardioversion. Start at 100, increase to 150, and then to 200 joules. If they're in refractory unstable tachycardia, you can double the initial dose to 200 as you need. And the manufacturers all recommend placement of pads for synchronized cardioversion is the anterior-posterior positioning. But if you need to adjust the location of the pads, you can do that if you're not successful. Now remember, of course, with synchronized cardioversion, you're assuming the patient, well, most of the time the patient has some cognizance of what's going on, so you need to sedate them. Okay, medications, changes, nitroglycerin. Most of our nitroglycerin in the county is 0.4 milligram tablets. Nitroglycerin is an organic nitrate. Vasodilating agents, cardiovascular effects include reducing venous tone, which causes pooling of bloods in peripheral veins, decreasing return of blood to the heart, so it drops your preload, decreasing peripheral resistance, drops your afterload, and dilatation of coronary arteries. It's also a general smooth muscle relaxant and actually has some GI effects as well. Indication is chest pain thought to be cardiac related and pulmonary edema. In pulmonary edema, you're trying to get the effect of the venous pooling, decreasing the preload. Now, contraindicated blood pressure, less than 110, so that's a MAP of 65. Patients taking phosphodiesterase inhibitors, Viagra, Levitra, Cialis, etc. And, a lot of people do not they know it only by the brand name, not by the generic name. So you have to be aware, just to ask that. A lot of times they forget to tell you. So in chest pain, acute coronary syndrome, administer oxygen if needed, if they're less than 94 to 98%, obtain, or 94%, obtain a 12 lead and do this concurrently with the treatment. Our goal with ACS is to get a 12 lead in less than 10 minutes of your arrival at patient side. Aspirin 324, nitroglycerin 0.4 milligram. Now, I know many of you still have the nitro sprays. Nitro spray is quite expensive, and the reason we were trying to get around this is that it is expensive, and strictly speaking, particularly with COVID and the like, nitro spray is meant for the multi-dose nitro sprays are meant for one patient only, really, because you're sticking this thing in the patient's mouth. You're going to get some aerosolization back, and it's, you know, I know it's quick and easy, but it may not be as effective. And we can continue to use the nitro spray if we have it until it goes out. But then I think at this point, I prefer you to go to the nitroglycerin 0.4 milligram. And it's been raised that perhaps people have dry mouth. That's not going to dissolve. There's all the anecdotal things that we've found undissolved pills in somebody's mouth. Yeah, but you can put a drop or two of water in there too, for that matter. Fentanyl, 25 to 50 micrograms IV. If they cannot take the nitro due to low blood pressure, then you can titrate some fentanyl to them. If they're hypotensive, follow shock protocol, etc. Now, in pulmonary edema, set the patient up, let gravity help you, dangle legs if possible. We're not doing a rotating tourniquet. So if the patient is having significant difficulty with their respirations, use a CPAP, or if you're assisting ventilations, use the PEEP valve. And then nitroglycerin 0.4 sublingual every 3 to 5 minutes if their blood pressure is above 110. Now, we're kind of analyzing our records to see whether we are actually seeing there's sort of hypertensive crises, pulmonary edema crises, where you have pulmonary edema and you have hypertension as well. And in those cases, so flash pulmonary edema with severe, with concurrent hypertension, there may be a reason to ultimately go to nitroglycerin drip, but I want to analyze our data and see how many cases we see like that, because nitro drip is a little bit touchy to manage, and it would take quite a bit of additional training. Now, nitroglycerin, always caution in right-sided myocardial infarction. Now, if they're hypertensive, that's okay, but most of the time, right-sided myocardial infarction is normotensive. And if you use nitroglycerin, you're going to drop the preload, and the right heart is entirely depending on preload to maintain blood pressure. So you can get a patient very hypotensive very quickly. Now, changes in calcium gluconate. What do you use calcium gluconate for? Suspected calcium channel blocker overdose, mostly though for hyperkalemia and for cardiac arrest, PE asystole, especially if in patients who were suspected of having hyperkalemia, they're diabetic, they may be in diabetic ketoacidosis, etc. Adult dosing is not, we've changed this to milligrams. Adult dosing, average adult is 200 milligrams slow IV or IO. Pediatric dosing is 10 milligrams per kilo slow. So basically that's 2 amps of calcium gluconate. The amount of calcium in calcium gluconate is significantly less than the amount that was in calcium chloride, but but it's a much much nicer formulation. If you've ever seen somebody extravasate calcium chloride into their anticubal space, it's pretty nasty, and so the calcium gluconate just doesn't do that. Whoops. Okay. So hyperkalemia. Treatment of suspected hyperkalemia. So suspect in a known renal failure patient or a dialysis patient or in a patient who's had a perhaps a crush injury or who has been even laying immobile on a floor for a prolonged period of time so that they have some rhabdomyolysis occurring and have acute renal failure. Also suspect in heat syndromes, etc. Now, patients who are predisposed have muscular dystrophy, paraplegia, quadriplegia, prolonged immobilization, or serious burns. You don't have to worry about burns in the time that you're seeing the patient acutely, because the burn injuries, hyperkalemia, occur at least 48 hours after the event. Obviously, you want a 12 lead, and the 12 lead will give you some hints, particularly if you have peak T waves. Also remember that the endpoint of hyperkalemia is basically loss of P waves, widening of QRS, approaching a sine wave pattern. In other words, the patient looks like they're going into a cardiac arrest, because they are. IV fluid of choice. Calcium gluconate, slow push. Sodium bicarbonate, 1 milliequivalent per kilo, slow push. Albuterol, 5 milligram continuous med-neb with a max of 20 milligrams. Now, follow any procedures for for dysrhythmias, and then for most, you're going to be following the 12 lead. Your 12 lead should improve. For most of your, in most of your cases in the city area, you're not going to be with the patient for that long a period, maybe 20 to 30 minutes. But if you get an improvement in your 12 lead and they start to go back to where they what their 12 lead originally looked like, with peak T waves or widening QRS, then you can repeat the calcium gluconate, and you can also repeat the sodium bicarbonate, but this time do it at 0.5 milliequivalent per kilo. For poisoning and overdoses, so calcium channel blocker, overdose. For the adult, use calcium gluconate, 200 milligrams slow, IV. They treat bradycardia and shock per protocol, because frankly, most of the time, even though we give the calcium gluconate or calcium chloride in the old days, it really doesn't get them out of the shock at that point. You need to use an epi or norepi drip and use an epi drip if they're bradycardic as well. So, and of course, pediatrics is 10 milligram per kilo. Now, little change to intubation, post-intubation procedure for sedation. We've had a lot of discussion at the medical director level about appropriate sedation. We generally don't use Versed to sedate patients post-intubation in the hospital. We're using other things, including ketamine. So we're going to add back in to post-intubation. Remember, the most important thing to give first is the analgesia, which is pain medication, which is fentanyl. And the fentanyl is given at 50 to 100 mics, depending on the size of the person and the age of the person. Obviously, the older person, you use the lower doses. 50 mics, IV or IO every 10 minutes. And then for sedation, so you don't generally need to go to sedation until you've at least maxed out at about 100 mics of fentanyl. So give 2 doses, because that would be the treatment to start with. If you used ketamine for induction, we'd have you go to 2 milligrams per kilo slow push. In other words, basically an induction dose. Beginning about 15 minutes after you had given the initial ketamine. Now, if you hadn't used ketamine, you could still, for induction, you could still use ketamine at that level, beginning about 15 minutes after you've given some fentanyl. Now, obviously, if the patient is bucking the tube and is showing signs that they really are light, then definitely you can give the ketamine. But don't forget, we definitely want you to get the fentanyl into the person first. Now, if you have no ketamine available, you can use midazolam, 5 to 10 milligrams. It can be repeated. The ketamine dose can be repeated as well. Now, be sure to tell the ER doc in the ER when you come in that the patient has had a dose of ketamine and when. Just like you tell them when they had a dose of midazolam. Okay, jumping into other medications, we're going to talk about a new medication, which is an oral disintegrating tablet, ODT, of olanzapine, which is also known as Zyprexa. Olanzapine is an atypical antipsychotic. It's a dopamine and serotonin antagonist. It has anticholinergic, antihistaminic, and anti-alpha adrenergic effect. It's indicated. It's indicated for patients with psychotic symptoms or mild agitation who are willing to take an oral agent. And the idea is to start early treatment for psychosis and or agitation. The only only absolute contraindication is a known hypersensitivity to the drug. You have to ask people if they've hand knee problem. So you would recommend, you say, look, you seem to be awfully anxious and agitated. Would or would you like to have a pill to try to improve your sense of wellness? And pregnancy is a relative contraindication because it's never been tested in pregnancy. It's only for adults, so 18 to 65 years of age. It doesn't work well at people my age. It doesn't, because it can have some real downsides. So it's not for the elderly. May prolong QT, but it's unlike in a single dose, just like any other of the antipsychotics seem to do that. Can cause orthostatic hypotension or bradycardia, but usually they're quite agitated at that time. It won't help. It won't hurt to slow them down a little bit. Low incidence of extrapyramidal effects. Elderly patients are at risk to cardiac events. Administer a tablet immediately after you remove it from the blister unit. It's tightly packed. Tablets disintegrate in the mouth, can be swallowed or with saliva or with liquid. Onset of action is 15 to 30 minutes. So if you have a 30-minute transport, you may or may not see much effect. Patients who receive olanzapine may be transported to alternative behavioral health facilities. And this thing to move over for me. There we go. Now, so this brings us up to the agitated patient management. We have changed this. It used to be combative. There's, I don't know. I'm sure many of you have been following all the action in various legislatures around the country, particularly Colorado, but Washington also did quite a bit this year, limiting the actions that police can take in doing restraint of combative or agitated patients, and so we have to be aware of all that. And
Dr. Weber, could I just jump in with one clarification about what you said about olanzapine?
Sure.
And you mentioned patients being anxious and feeling anxious. I just want to clarify, because there's potential for confusion here. These are patients that are anxious because of psychotic symptoms,
Right.
Not just generalized anxiety, but the delusions or the paranoia. Those are the things that are making them anxious or making them feel agitated. But and as you said, the goal is you likely won't see the effect of this medication during your transport, but the goal is to start treatment for psychosis and hopefully prevent more severe agitation later on in their hospital course.
Right.
Thanks for letting me jump in.
No, thank you for that clarification. So in our agitated patient management, this should be used only if the patient's a danger to self or to responders. Use all of the means available to de-escalate the situation. Consider reversible cause of combativeness, such as hypoglycemia, post-ictal phase, etc. So if a patient has psychotic symptoms or mild agitation and is willing to take an oral agent, then use the olanzapine 5 milligram ODT or offer it to them only in ages 18 to 65, may be administered prior to transport to alternative mental health facilities such as the county acute crisis intervention center or to Rainier Springs if they will take. Now, with physical restraint, use the minimal mobile restraint required to ensure patient care and safe transport. call for law enforcement as necessary. We're going to have to be, we're in the midst of having all sorts of conversations with law enforcement about how and when they will be involved. Now, do not endanger yourself or your crew. So if the patient is totally uncontrollable and you do uncontrollable, totally agitated, you do not have and you do not have enough manpower or police assistant to restrain them safely for yourself, then do not put yourself or your partners at risk. You may disengage. Sometimes that improves the situation. Place patient face up, secure all extremities, but no handcuffs or chains. Use C-spine precautions as necessary to control violent head or body. Evaluate respiratory and cardiac status, monitor SpO2 and ETO2. What should be on this as well is to attempt to establish that the patient is either hot or you can actually get a temperature. If the patient is totally agitated, you're unlikely to get a temperature on them unless you have a thermal scan. Because the hallmark of agitated combativeness, what used to be called excited delirium, is that they are hyper, but they're also hyperthermic. Now, medication, new medication, old medication, back again. One of our favorite medications for sedating and for helping to calm the psychotic patient. Peridol, also known as anapsine. Peridol is a neuroleptic agent, produces tranquilization and sedation, reduces motor activity, anxiety, adrenergic blocking, antifibrillatory, antihistaminic, anticonvulsive. Sounds like it does everything. It's also antiemetic, causing dopamine receptor blockade in the brain, so it has a strong anti-dopaminergic, anti-serotonin response. Now, this should be number C. I noticed that last night when I was rereading all these things, is that this should be number C. The onset of action of droperidol is 5 to 10 minutes IM, 3 to 10 minutes IV. Full effects are usually within 10 to 30 minutes, lasts about 2 to 4 hours. Indication is sedation of agitated patients to facilitate management or as an antiemetic. Now, precautions, just like with Haldol, and orthostatic hypotension can occur. Caution with other CNS depressants, so tranquilizers, alcohol, narcotics. And we do a cardiac monitor during transport. It's because all these drugs have been reported to have some QT prolongation. If you know that the patient's on a QT prolonging drug, I would not use this to sedate them. For example, if the patient if part of the problem is they've taken an overdose of a tricyclic. Tricyclics work by one of the things they do is prolong the QT. I would not give someone something else that prolongs the QT. But generally speaking, we have not had any problem with Haldol or with droperidol used at the levels we use it. If you're monitoring a patient who's combatively agitated, you should probably have at least a monitor on the patient. Hypotension usually responds to position and to fluid boluses. Occasionally, they get what are called akathisia, restlessness, creepy, crawly, icky feeling, and they can't sit still, and they get really agitated. Occasionally, a dystonic reaction is reported, but all of those, including akathisia, can be treated with Benadryl, 50 milligrams IV for the adult, and that takes care of 90% of it if they have any agitation after that, or if this doesn't take away their symptoms after about 3 to 4 minutes. Kiss them with about 2.5 milligrams of Versed. Now, obviously, use a lower dosing on elderly and smaller patients. We've had a few bad results of old people getting fentanyl and Haldol, getting fentanyl and Versed, and being really, really narcotized by the time you get them to the hospital. I mean, to the point where they literally have to be intubated. We don't want to see that sort of thing. Now, the agitated patient, you think it's thought to be psychiatric or unknown, Peridol 5 milligrams IM. You can repeat it after 15 minutes to a max of 10 milligrams. Or 2.5 to 5 milligrams IV. Repeat again at 15 minutes to a max of 10. Now, severe agitation, which we will still call it excited delirium, but it's severe agitation. This is give 10 milligrams IM Peridol followed by 5 milligrams of Versed IM. Now this is less than you. Peridol works quicker and has significantly more sedation than does Haldol. So the sequence used to be 10 milligrams of Versed IM followed by 10 milligrams of Peridol, because frankly 10 milligrams of Haldol, because the Haldol was such a slow actor that now this should work much better in a smaller dose. Now, it's an excellent drug for nausea. So as an alternative to Zofran, 1.25 milligram IV or IM. It's a very small dose. You don't want to go above that. Now, with pediatric dosing, pediatrics can be dosed at 0.1 milligram per kilo IM. Now, generally speaking, we don't give children under the age of 2 anti-nausea drugs anyway, so we don't really have to worry about that. So, if the patient's agitation is unknown or suspected to be psychiatric, Peridol or Haldol. If the cause of agitation is drug ingestion, withdrawal, or post-cyclostake, that's where we use the Versed 2.5 to 5 milligrams IV or 5 milligrams IM. Don't use Haldol and Peridol concurrently. You notice we've dropped out Geodon. It's kind of, it's a slow-acting drug. It takes a lot of it. You can only give it IM, can't give it IV. There's no need, as long as we have Peridol and Haldol, there's no need to be carrying that. It's a little bit more expensive too. But you can obviously work it out of the system by letting it expire. For severe agitation, Peridol 10 milligram with 5 milligrams of Versed. Now you can substitute Haldol for the Peridol, but you should give it at 10 milligrams of Versed along with this. So you remember that one of my tests for whether this is severe agitation or excited delirium is that if you can't get to this patient with an IV, you have to give it IM, and the patient's hypertensive, he's tachycardic, tachypnic, and hot. Call it severe agitation combative agitation, and you have to, and I would give them the Peridol in this dose, 5 milligrams of Versed. If you only have Haldol, I would go to Haldol, Versed at 10 milligrams, followed by the Haldol at 10. Now, pediatric patients, the Peridol in this dose is Haldol. We haven't changed the dose of Haldol, and the Versed is a milligram per kilo IV or 0.2 milligram IN or 0.3 milligram IM. Now, generally speaking, we don't have to go, we're not going to be that carried away with our little agitated patients. Vomiting, significant nausea, we've added the Peridol 1.25 milligram IV. Pediatric patients, we've not gone away from the ondansetron for pediatric patients for nausea. Generally don't need to treat kids for nausea. Consider, now remember, one of the other things to consider for nausea is the isopropyl alcohol swab and inhalation. It works on some people. Now, pain control. To facilitate pain control, particularly if there's nausea associated with it, Peridol would be preferred, 1.25 milligram IV. And pain control in children, 0.1 milligram per kilo. All right. A couple of changes, as you're all aware. We've been having a lot of divert from the two hospitals at various times. Sometimes the basic rule that we've gone is that the diversion is really a hospital issue. Shouldn't become an issue for EMS. So we are working on this with the hospitals, but if at this present time, if Peace Health or Legacy are on divert, if one hospital is on divert, the destination hospital will generally be the other Clark County hospital. Now, of course, that doesn't work for, even if Peace Health were on divert, unless there was an internal disaster, they would not be on divert for STEMIs, for traumas, for stroke, etc., for major stroke. Now, if both hospitals are simultaneously on divert, then no one's on divert. And it will transport the patient to the closest, most appropriate Clark County hospital. And we are working with them. Dr. Mocht and I and Dr. Gadbois are working with the administrations. Our basic, we're going on the assumption that Clark County should not have divert from a hospital unless they have an internal disaster. We've had a couple of occasions, the shooting at Peace Health a year or so ago, the vaccine objectors who basically closed down the Legacy Salmon Creek back a few months. That's an internal disaster. It's kind of out of control. Occasionally, some major thing like the water went bad one day. There's sewage breaks and things like that, and those are kind of uncontrolled issues and legitimate reasons to close down a hospital. But divert from an ER should not occur as a rule. So we're going to be stressing that with them. Now, As you know, we have the SERV van, the Sober Urgent Response van, which is available sometimes of the day. It is now starting up again, and it's to transport patients to the sobering center. Now, sometimes it's not available, and it is allowable now by state law to transport a patient to the sobering center, to an approved sobering center, or to an alternative behavioral health plan by ambulance, with a couple of caveats for sobering units. That the eligible individuals have to be 18 years of older. They have to be under the influence of drugs and alcohol. They need to have a BAC of 0.35 or less. Now, that is currently measured by the SERV group or by law enforcement. We don't have them on our regs, so you would not know that. And the patient has to be willing to go, and a GCS of 14 or greater. And the most important thing is who's not eligible to transport to a sobering center, and basically it's the same rules as who's not eligible to go to an alternative behavioral health center. If they're having chest or abdominal pain or shortness of breath, potential fractures or injuries requiring ED evaluation, vital signs with low heart rate or tachycardia greater than 100, temperature greater than 100.3 or less than 98, and this is all in Fahrenheit. Blood pressure greater than 180 or less than 100 systolic. Blood pressure greater than 100 diastolic. Respirations greater than 24 or less than 12. Unconscious, BAC 0.35 or greater. Blood glucose less than 70 or greater than 300. Those would be appropriate to go to the ED for evaluation. Now, if the SERV is unavailable and all of the above criteria met, the individual may be transferred to a sobering center by an ambulance. You have to fill out an ambulance, your regular MIR, no matter what. If the BAC is unavailable on scene, treat and transport to the ED per protocol. Now, so obviously, if police hasn't been there, and because they'll just turn them around at the sobering center if they blow more than the 0.35. Contact the sobering center to determine bed availability. There's the number, just like you would contact the acute crisis center or Rainier Springs. Contact medical control, provide a brief description, request permission to transport to sobering. It's not the intent of this protocol for EMS to serve as the de facto transport means. We want the SERV to continue doing its stuff. So it's just going to be on unusual circumstances that you might be asked to transport. Couple of things. This is the medical examiner information sheet. So it's worthwhile reviewing at the time. It's in your protocol book. So review this when you're going to contact a medical examiner as per death in the field protocol. This is the kind of information they need: name, age, date of birth. Gender, address of the incident, date and time of death, time decedent last seen alive, name of paramedic and agency, medical treatment, if any, note any invasive procedures, etc. Leave those devices in place. Be prepared to answer: how was the decedent feeling? What was the decedent doing before they died? What was the death event witnessed by? How and where were they found? What was their body position and clothing? What death signs were present? Were they moved from the original position? Funeral home, if known. and with children, file child infant death scene and crimes. If crime scene is confirmed or suspected, follow the guidelines there. And of course, those are also in your protocols. All right, I think that that is the extent of the things. Dr. Mock or Dr. Gadbois, any comments or concerns or things that I sort of eluded?
No, you covered it. Nothing else. Nothing else to add from my point of view.
Any questions at this time?
Just a comment. So the protocols have been provided to all of the agency EMS supervisors, chiefs, etc. So these will be disseminated once the program is watched or viewed. So these will be in place as soon as you watch this particular program. So contact your agency EMS supervisors for copies of the protocols.
Okay, well, hearing no questions, I'll give you back the rest of your day. Thank you.
Thanks everyone for coming.
Thank you guys. Have a good day.